Hello everybody, welcome back. Today we'll be going through the mediastinum some more and focus on the aorta. So inside the mediastinum, there's going to be anterior to the aorta, the thymus, then the venous layer, then the arterial layer. Along with the cardiac plexus and the other nerves surrounding the arch. And then posterior to it is going to be the trachea and esophagus, and lateral to it are going to be the thoracic ducts. So the ascending aorta, it comes from the left ventricle, of course, at the angle of the sternal angle, so right at your sternum and your manubrium. And this ascending aorta does lie within the fibrous pericardium, so it's a part of the pericardial sac. And behind the cusp of the aortic valve are going to be the sinuses of the aorta. And it sounds really confusing, but actually it just means like there's just like a slight like bowl-shaped ring in the aorta right above each of the cusps around the cusps. And then it's going to branch into the right and left coronary arteries in the neck. So in the arch, there are going to be baroreceptors, and those are going to be innervated by the nerve of Scion, which is a branch of the vagus nerve. The aortic bodies are chemoreceptors. The left bodies are going to lie between the left subclavian and the aorta in this space, and then the right are going to lie between the right subclavian and the right carotid. These are of surgical importance because you do not want to be damaging the baroreceptors. That'd be awful. This person, the patient you'd be operating on, wouldn't be able to equalize their blood pressure if they are damaged. So the arch is also related to the left brachiocephalic vein and medially to the trachea and esophagus, like right behind it. What's important to know is that the right pulmonary artery and the left principal bronchus will go right under the arch. And connecting the pulmonary artery to the aortic arch is something called the ligamentum arteriosum. This doesn't have any clinical physiological importance, but it's important for us as clinicians to identify, because right at the ligamentum arteriosum is where the recurrent vein, the left recurrent laryngeal nerve, goes right under the arch. So you don't want to be damaging that, because the patient would have difficulty speaking and swallowing if that is damaged. So this is a good landmark to know, like, hey, be careful in this area, especially if you're trying to do some kind of like aneurysm repair. Also important to note is that the phrenic nerve will cross over the brachiocephalic artery and the right atrium to the diaphragm over, the right and left ventricles along the left side. So you got to be careful that the phrenic nerve, which is a branch of the right vagus, is going to descend and then cross over the heart. Okay, so the branches of the aorta or the aortic arch, there's going to be the brachiocephalic artery, and that divides into the right subclavian and the right common carotid. While on the left side, it's going to be the left subclavian. Here's the brachiocephalic trunk. So on the right, it branches off into, it's one trunk and it branches off into the carotid and subclavian. And there are variants, so here are a couple variants. You don't have to memorize them, but just know that there are variations. Not everybody has just the two trunks. Some people have three, some of them have connections. But the most important variant is some people have something called a thyroid edema, and it's an artery that will supply the thyroid, and it comes directly from the aortic arch. So nicking this artery can actually lead to death, because it's a high pressure artery, and there's a lot of blood, of course, coursing through the arch of the aorta. So if you're doing any thyroid surgery, make absolutely sure that you're gonna ligate this thyroid edema if it exists. It's not in everybody, but if it exists, you have to make absolutely sure to ligate it before operating. Okay, so an arch aneurysm, unfortunately, is more common in men, especially middle-aged men, and it's just the weakness of the aortic arch walls, and it causes this bulging, and the bulging is concerning because it's a high pressure vessel, and the more blood goes through it at higher pressure, because the aneurysm usually occurs because of high blood pressure and some kind of cardiac problem. So with the high blood pressure and increased contractility of the heart, of course pressure is going to build, and without repair, if it ruptures, person will die very, very, very fast, because first they go into hypovolemic shock, and then there's going to be internal bleeding, and bad news. It's a whole mess to fix. It's really common in people with Marfan's or Ehlers-Danlos syndrome. Remember, because there's going to be a problem in Marfan's with elastin, and in Ehlers-Danlos there's going to be some problems with collagen formation, but in both cases the vessel walls will be weak and fragile and prone to aneurysms. Luckily enough, there are repairs. You can do grafts. You can do a partial graft and bypass, and in the worst case scenario, you'd have to do a full open chest and replace the entire arch with a stent. So Takayasu's disease is also known as aortic arch syndrome, and it's a non-specific aortoarteritis. It just means the inflammation of the aortic arch, and it's going to cause a narrowing of the arch. So though it looks indicatively, as you can see, I can't even speak, sorry, but it looks very, inflamed and gorged, but remember that the inflammation works both ways, so it spreads outwards but also spreads inwards. So inside is going to be almost ischemic, so the lumen is going to be a lot smaller than in a normal arch, even though it's bulging like that. It's also known as pulseless disease because there's not going to be any blood going to the distal extremities. So if you try to feel the pulse in somebody's radialis or in their dorsalis pedis, you're not going to feel anything. In fact, they might be the skin might be almost blue because of the lack of oxygen and lack of blood. And there's also a physical exam that you can do called the capillary refill, where you press on the finger or the toe and wait how long it takes for the skin to pinken. Somebody with this disease, or any kind of ischemic disease really, when you press their fingers, it's going to stay white for a long, long time. Unfortunately, this is found more in Asian women, and if untreated, the risk of aneurysm is pretty high. So the common carotid divides into the external and internal branch, and it's embedded in the sheath that comes from the cervical fascia, of course, and there you go, here it branches off. It comes from the brachiocephalic trunk on the right, and it comes from the arch directly on the left. So in the front, there's going to be the skin, the fascia, and the muscles. Posteriorly is going to be the nerves and the vertebra. Medially is going to be, the larynx, pharynx, tracheus. And then laterally, more importantly, are going to be your internal jugular vein, along with your vagus nerve. At the thyroid level, the carotid will split into here's the external, there's the internal, goes deeper into the neck. Here's the arch. So common carotid stenosis is problematic because, as you can see here, it's going to block both the external and internal carotid arteries. So in this case, you have to do an endarterectomy to remove the plaque. But this is dangerous because you might hit the superior laryngeal nerve. Okay, so the internal carotid supplies a major part of the brain, the eyes, the orbital muscles, the face, and the nose. As you can see here, it goes up into here and above the foramen lacerum, not through. The board might be able to trick you if they say, oh, the internal carotid goes through the foramen lacerum, but it doesn't, because the foramen lacerum is closed by cartilage. So just know it goes above, and it goes in the carotid canal, and it goes through the cavernous sinus, and it's separated by everything by the dura. It runs back from the optic chiasm and splits. So it runs to the optic chiasm, splits to make the anterior and the medial. Here's the anterior cerebral artery and the middle cerebral artery. And then from there, there's a bunch of other branches. So here it goes. Here's your basilar artery. This is the back of the skull. All right, and then here's your internal carotid in the neck. And then this branch goes to the eyes. This goes to the cerebral. This goes to the middle cerebral. Here's another nice little picture. So the carotid sinus is the dilation in the beginning of the artery, and the tunica media of the sinus is going to be thinner, and the adventitia thick, and those things have the baroreceptors, and that monitors the blood pressure, of course. The glossopharyngeal nerve is going to innervate it, and it receives the information, while the vagus nerve that also innervates the carotid sinus responds. So the sinus, what does it do? It is a reflex presoreceptor. So a rise in blood pressure will cause the slowing of the heart and a vasodilatation of the arterioles. Why? So usually a rise in blood pressure is a sympathetic response. So this is going to be a parasympathetic response to perfuse the tissue again and to slow the heart rate. When you palpate a patient's neck in order to feel the carotid, you're actually not feeling the internal carotid, you're actually palpating the external carotid, and in particular the carotid sinus. So that's where you actually feel for the pulse. So here are the receptors, the internal, external. Remember, the internal is more like, kind of like posterior. I don't really like this picture, but it's the way it is. It's more like kind of on this side. It's more like lateral, posterolateral. So a hypersensitivity to this reflux response will cause fainting at any kind of slight pressure. In some cases, like you can just press externally on the carotid sinus and it will cause somebody to faint. Usually it's more like in tall people or in people with some kind of genetic predisposition to it. It's when they sit up and they feel dizzy. So the carotid bodies, they're going to be at the bifurcation. They're innervated by the glossopharyngeal nerve, and that's going to be cranial nerve number 5. And these are chemoreceptors. The reflex produces a rise in blood pressure and heart rate and increase in respiratory movement. So this is going to be a sympathetic reflex. So the carotid in the neck the internal carotid has no branches in the neck, so it's a little bit easier to identify. And it lies below the digastric, I want to say posterior to the digastrics, and it lies medial to the parotid gland in the cheek, along with external carotid gland. And posteriorly, there's going to be the nerves and the neck muscles and the vertebra, of course. Medially, it's important to note that the superior laryngeal nerve is going to be in front of the internal carotid, and laterally, the internal jugular vein, and the vagus nerve. Well, the vagus nerve is more like posterolateral, but important to know. So here's the parotid, external, internal is like a little bit behind. Here are the glossopharyngeal, and here's the pharyngeal branch of the vagus nerve. Okay. Once it goes deeper, it branches in the head. The ophthalmic artery, of course, provide supply to the eyes, and it runs through the optic canal. The central artery of the retina it's like direct continuation, and it passes through the actual substance of the eye into the retina, like through the subarachnoid space, and you can see it during like ophthalmoscopy, and it's used to detect retinal vascular diseases, so in diabetic patients like glaucoma, because the swelling of these branches will lead to a stasis of blood, and that causes like blurred visions, painful intraocular pressure. And they have a bunch of branches too. The other branches, the superior and supraorbital, will supply the forehead. So the muscular branches will like supply the eyelids, the orbit. Ciliary muscle is like a muscle in the eye that helps like contract the retina. Lacrimal, of course, they'll innervate like the tear ducts. Posterior ciliary artery will also help like contract or relax the pupil. The dorsal nasal will, of course, supply the nose, and those anastomosed with the facial branch. And then a posterior communicating artery runs backward. Here's the anterior communicating, and that is going to be the terminal branch. Those go into the cerebral hemisphere. The posterior will communicate with the posterior cerebral artery. Here's the posterior communicating. It's very small, as you can see. So, going back to the anterior cerebral artery, that goes around the corpus callosum and is joined more or less in the front of the brain by the anterior communicating artery. The middle cerebral artery is an important landmark because it's the largest terminal branch, and it runs laterally in the cerebral sulcus, so easy to identify. And those supply like a good deal of the cerebral hemisphere, the basic ganglia, the nuclei, and the cortex. So going through the head again, here is the internal jugular or internal carotid artery, and then here's the posterior communicating, and then branches towards the front. You get the anterior cerebral, and those connect to each other with the anterior communicating arteries. And then in the back of the brain, towards the brainstem, is going to be the basilar artery, like also like going up, and that anastomose with the anterior cerebral artery using the posterior communicating. Okay, so going through it again, this is actually known as the circle of Willis. So it's a communication of the arteries in the subarachnoid space at the base of the brain. And importantly, it's anastomosis of the internal carotid artery and the vertebral artery. So the vertebral arteries come from, like, the vertebra, of course. And those will join in one big trunk called the basilar artery. So if you ever get a basilar stroke, that's bad news, because look how much it, supplies along with the communication. So here it goes, up, and then from the neck, there's going to be the internal jugular or internal carotid artery, and it communicates with each other using the posterior communicating artery. Okay, atherosclerosis, of course, can cause all sorts of problems. In the eye, we use arteriography to identify like the blockages right here, right here, right here. Here's a healthy eye. Aneurysms, of course, same kind of hazard as in the in the aorta, but instead of having just kind of hypovolemic shock, a person will suffer a hemorrhagic stroke. So a hemorrhagic stroke is not quite as bad as an ischemic stroke because the body can kind of compensate from it. They can just like reabsorb the blood and stuff, and there is an actual brain tissue death because it's still being like, you know, oxygenated. It's still bad news, but it's not quite as bad as an ischemic stroke. And these are bad because you really can't tell. There's not really any signs until they've ruptured, or you've just happened to have a head MRI. But they do show up quite well. Like, here's a big old aneurysm right here. There are ways to treat it. You can ligate the aneurysm by putting a coil in to just kind of like burn it away. You can also use some kind of like chemicals to ligate it, and usually there's some kind of bypass that occurs that is, you know, used to treat this. Okay, so that's it for now. Thank you for your attention and good luck studying.